We here at the Institute of Colorectal Surgery at Apollo Main Hospital, Chennai, are one of the busiest colorectal units in the country. We provide a comprehensive end-to-end care for all colorectal problems, which include hemorrhoids or piles, anal fistula, anal fissures, ulcerative colitis, Crohn's disease, diverticular disease, and of course, colorectal cancer. The Institute of Colorectal Surgery has a comprehensive team of physicians, surgeons, physician assistants, nursing staff who provide a comprehensive care for all our patients. One of the important aspects of the care we provide is day surgery or one-day procedures. Majority of our surgical procedures are done in a daycare model so that patients get admitted in the morning, have their surgery, and they discharge the same day. The month of March is Colorectal Cancer Awareness Month around the world. Some of the important risk factors for colorectal cancer include a sedentary lifestyle, obesity, smoking, consumption of alcohol, and red meat. Some of the important symptoms for colorectal cancer include rectal bleeding, change in bowel habit, anemia, weight loss, and sometimes finding an abdominal lump. If you have persistent symptoms for more than 6 weeks, you should go see your doctor and get screened. The gold standard test for colorectal cancer screening is colonoscopy. Rectal cancer surgery has evolved into a very specialist surgical procedure. Surgeons in our institute are specially trained to perform these procedures. Someone who's diagnosed with low rectal cancer is at risk of losing their normal route of passing motions or defecation. With these advanced techniques such as robotic surgery and highly specialized training, surgeons in our institute are able to remove this tumor and reconstruct it so that permanent stoma is avoided in these patients. With robotics for colorectal cancer in particular, we see that the procedures are quicker, there is less blood loss, there is quicker recovery for patients, early discharge from hospital, and a quicker return to normal work.
Good morning, everyone. Welcome to this webinar. Welcome to this webinar. Along with Apollo Hospitals, the Hindu Wellness Webinar today presents an edition on colorectal cancer, its treatment, and the way we can prevent it. Welcome, Dr. Venkatesh Munikrishnan.
Thank you, Mrs. Sujata.
Dr. Venkatesh Munikrishnan is a consultant colorectal robotic surgeon. He is the clinical lead at the Institute of Colorectal Surgery in Apollo Hospitals. He is the national lead robotic colorectal surgery program, again at Apollo Hospitals. He is the honorary senior lecturer in surgery in the University College of London. He is the examiner in Royal College of Surgeons of Edinburgh. His specializations include colorectal cancer surgery, surgery for benign colorectal disease, surgery for inflammatory bowel disease, proctology, therapeutic colonoscopy, emergency surgery, and daycare surgery. Dr. Venkatesh is a fellow of the Royal College of Surgeons and has been admitted to the Specialist Register of General Medicine Council, London, UK. Welcome, Doctor.
Thank you again.
We will start with a presentation from your side on what exactly is colorectal cancer and the various facets of it.
Sure. Thank you to the Hindu and for inviting me and Apollo Hospital supporting this program and creating awareness about colorectal diseases. So just to give you an insight before I start this presentation, a short presentation on robotics, is that in general, we've seen that over the last 20, 30 years, there's lots of specialization in every field, facet, in every profession. And so has change been in medicine and surgery as well. And we know that, if you go back 20, 30, 40 years, there were lots of generalists. Now there is specialization. There are doctors who do very specific work. The reason why we do that is that you could become more experienced and you could treat disease better. As disease processes, diagnosis, and treatments become complex, you need somebody, or a doctor in particular, to focus on that particular area so that we could give the best to the patient. So similarly, if you look at general surgery has been everything to do with, surgery of, the thyroid or the chest or abdomen. Over the years, we've seen that it's all split into vascular surgery, gastrointestinal surgery, urology. And then further in gastrointestinal surgery, there has been subspecialization into upper GI surgery, which is to do with the food pipe or gullet, stomach, pancreas, liver, and further bariatric surgery to do with, obesity, and then colorectal disease, the colon and rectum. So when I went to train to England, that was in late 90s, subspecialization started over there already. So by the time I came to specialist training, they said, what they were offering is to go and deep dive into a particular area, so you could become an expert, so that your patient outcomes are better and complex treatments could be delivered. So when I moved back to Chennai and when I met Dr. Pratap Reddy, our chairman, the concept of subspecialization was already there in different fields, bariatric surgery, liver transplant. And so it was the need of the hour to focus on colorectal disease, particularly, cancer and non-cancer have one center where we could deal with the problem. Now, most important thing is to create awareness. These programs, like what we're doing now, is to create awareness. We could have technology, we know what to do, but the public, the patients, or even general public should be aware of what colorectal disease is, so that when you have some symptoms, you could seek help. Because I could talk about robotic surgery and it will be irrelevant because and specialist centers, robotic surgery is all great, but is it relevant to me? So I think the reason I'm touching upon all this is very important, because colorectal diseases are becoming very common. 40% of urban population will have a colorectal symptom in some point of their lives. Particularly, our lifestyles are changing. We're eating out more. Exercise is less. COVID has complicated it. Further, smoking, alcohol, all these things have an effect on colorectal health. So if you look at what are the common conditions, it's benign and cancer. Benign could be simple things like, what happens around the anus, which is hemorrhoids or piles, anal fistula, which is an infection, or a fissure, which is a little cut. So all this is to do with, your bowel movement and what symptoms and then the other end is obviously colorectal cancers of the colon or the rectum. Now we'll concentrate on this in a minute, but I just want to give you the viewers a overall view that disease of the colon and rectum are common, and I told you about this common things affect the rectum and the anus. The other things could be ulcerative colitis, which is inflammation of the colon, Crohn's disease, or it could affect any part of the gut, and of course colorectal cancer. Now leave that there, and then we'll just look at symptoms, because that's important. These programs are there, as I said, to create awareness. So the most common symptoms are, and I'll tell you why it's important, are rectal bleeding, which is bright red rectal bleeding, or blood mixed in your stool. It could be change in your bowel habit, which could be constipation, diarrhea, or alternating between these two. Weight loss, anemia, which is, your hemoglobin levels are low. You can feel you can feel tired, and you can also feel a lump in your abdomen. Now, why are these symptoms? Why we said this webinar is about robotics? We said this is about colorectal cancer. Why are we talking about symptoms? Because symptoms for colorectal cancer and common conditions like piles, I think anything to do with the anus, a little bit of constipation, a little bit of bleeding, a little bit of lump, immediately, or any of these symptoms, the most first thing public patients will think is, oh, it's just piles. Let's me, just ignore it or go to the local chemist and get some medicine. The problem, as I said, is these symptoms are common for these simple conditions as well as complex condition like colorectal cancer. So if you have these symptoms for 4 to 6 weeks, and you've done most of these can be improved by lifestyle changes, by increasing your water intake, at least 3 liters of water per day, better diet, avoiding red meat, cutting down on alcohol, stopping smoking. All these things will improve your symptoms and should settle. But if symptoms persist for more than 6 weeks, then you should go and see a specialist or a doctor who you're comfortable with. But important thing is to have do a checkup and to have a rectal examination done. And I think patients should insist that if you have symptoms for more than 6 weeks, you should do that. This is very important because if there's one point I would like to send across today, even before the robotics thing, is that if you have these symptoms for more than 6 weeks, please go see a doctor. And this will save lives, and it will, and if you find a complex problem like a cancer early, you can treat it better and you can save lives. Okay. So I've just given you context of what colorectal disease, why specialization. So with specialization, if somebody does, it's like, I give the analogy of cricket, and if you look at Sachin Tendulkar, for example, he is a batsman. He can bowl. He's taken some wickets, but batting is what he is. He scores lots of runs. He can do a square cut. He could do a long run. So similarly in surgery, if you are a specialist in a particular area, you do more of that and you become better. The reason why you become better is that you do more of it again. And then in turn, you do better surgery, you have less complications, and ultimately your patients get the best outcome. So this is the context of what we're discussing. And Sujata, now we can go into colorectal cancer itself and treatment.
Yes, sir. Yes. So I think you said you have a presentation. Would you like to start with your presentation?
Let me just give a brief insight about colorectal cancer, and then I'll start the presentation. Now that we've looked at symptoms, so colorectal cancer is becoming a very common problem around the world. It's the third most common cancer, and the incidence of colorectal cancer in India is about 60 to 70,000 cancers per year, which is a big number, right? Now, the deaths from colorectal cancer are about 35,000 per year, right? Now, if you look at that, that's about 4 per 100,000. 4 per 100,000 is the incidence in India of colorectal cancer. If you look at the UK or the US, it is about 35 per 100,000. So the incidence is higher. But they all do have screening programs, and so their cancers are picked up early and earliest. In our country, it is not feasible because the incidence is lower. And so patients generally ignore symptoms or they present at a later stage. So what happens is the patients present at a later stage, so the treatments become more complex, right? So that's the problem we face in India. And also the other issue is that young Asian males are more prone to rectal cancer. Now, colon cancer and rectal cancer are different entities. Colon is a 2-meter tube. You eat your food, it gets into the food pipe, it gets digested in the stomach, it comes and goes through the small intestine where all the juices are added and digested, and the liquid stool or the waste, after all the important things are absorbed, comes to the colon, which is about 2 meters long, and all the water or the wetness in the stool is absorbed by the colon, and the stool is pushed ahead and finally stored in the rectum, and it's evacuated once or twice, based upon each person every morning, and that's how it works. Now the rectum stores the stool, and the anal muscles and the rectum together evacuate it. Now, if there is a problem in any, if there's a growth or a lump, you will get symptoms of bleeding, change in bowel, which we've discussed. Now, colon cancer, it's a long tube. If there's a bit of a tumor or growth in the colon, then you remove, surgery is a mainstay. You go remove that bit of the colon, and then you join the two ends together, and the final report will come, and based on the stage, you give more treatment like chemo if required. The treatment of rectal cancer, which is the last 15 centimeters of the tube, which before where the anus is, which controls the motion, is more complex because the treatments are different because you could improve the treatments by doing certain things. Like if it is a very early small tumor, you can still do surgery. But now most of the tumors we see in our country are more advanced, mid or low rectal tumors. Now, because of the location of the tumor in the rectum, where neck close to the anus, we just can't go cut it out because it can affect the control of motions, and that becomes a problem. So that's why there are lots of treatments which are available, which is like radiation and chemotherapy, which is given prior to surgery to shrink the tumor. And once that shrinks for 5 weeks, and now there are newer treatments where you can do upfront chemotherapy as well. So this treatment can go up to 2 to 4 months, and then you give a break, and then you perform surgery. So that's the standard treatment for rectal cancer. Now, rectal surgery itself for these tumors has been done traditionally through the open approach, and then more in the last 2 decades or so through laparoscopic technique. More recently, in the last decade, this technology of robotics is more widely available, and we've been using this for 10 years in the main Apollo hospitals, where different specialties, urology, GI surgery, cardiac, thoracics, ENT have started using it, and gynae too. And over the last 6 years, we've had a program for robotic colorectal cancer surgery, and which we find that is very beneficial to patients. Now, at this point, I'm going to share my screen so that I can introduce robotic surgery. Why, I'm sure the public would have, or our viewers would have seen what open surgery. I'll just get into this presentation, and then we'll.
Yeah, sure.
Okay, can you see my screen?
Yes.
Okay, so as Sujata introduced, I'm Dr. Venkatesh Munakrishnan. I'm a colorectal and robotic surgeon. I head the Institute of Colorectal Surgery at Apollo Main Hospital, Chennai. And so if this slide gives you a perspective of what we're looking at. Now, if you look at that surgeon who's standing next to the patient, there is a big cut. To look inside the abdomen, there is a tumor. You have to push things out to one side or show where this problem is, and then you have to remove that. Okay, you will have a bunch of surgeons, nurses around, and you do that. But the surgeon is standing, you cut the abdomen as big as you want to get a good view, and you do it. Now, if you go to laparoscopic surgery, what you're seeing is the surgeon standing next to the patient, and he's made small holes in the abdomen, which are like 5 to 10 millimeters, tiny cutie holes. And he's introducing these long instruments, which are, they work in biplanes. And he's looking at a screen straight on, which is so there's a camera which also goes into the abdomen, and there is a vision which connects. And the surgeon has to look ahead like what I'm doing, and seeing the screen has to operate. Find you put some gas in so that the abdomen is distended, and wherever the problem areas, the colon or the rectum, you go and remove the tumor. So here the surgeon is standing. You can see there's a strain on his neck. These instruments are straight, so you will have to manipulate it. And there is a skill set to it, and it's a long learning curve for that. And you have to, and you have an assistant surgeon to put the camera in. So they are not in the picture, but this is how the surgeon is standing, but you need other people to help as well. So if you look at the picture on the right, which is robotic surgery, so I'm just showing a console which a surgeon has sat. Surgeon's head is looking into the console, and you can see his hands are onto 2 joysticks like the video games we have, the PlayStations, very similar to that. I think some of the viewers may be using it, and you know what I mean. And in the foot are pedals. And the difference here is you can see the surgeon is sat, he's comfortable, his elbows are rested, head is rested. You get a 3-dimensional. I'll go into that further. And every movement which is done on the joystick is replicated inside the patient. Now, let me go to the next. So this is how a robotic system. This is a commercially most popular one which is available in the market, which is a Da Vinci Xi system. This is what we have in the Apollo Main Hospital. As you can see, there is a vision card which has got all the some of the tech which is need to do the dissections or the operation. There is a screen through which the team which is by the bedside can see. So this is a it's called the vision card, where you can record the operation, all those things. Now this is where the patient is lying, and you can see this is the actual robot, right? And you can see it's got a boom, and 4 arms which are, put or inserted into the patient. Now, these arms, one of them has got the camera, and the other 3 arms have got instruments which we can have. Now, there is also this console which I showed you in the previous picture, where the surgeon is sat looking into their, the console screen, and the pedals and all the controls are there. Now, let me see. So this is how it looks, and you can see the surgeon is sat there. You have the assistants there. Obviously it looks more complex. This is a simplified picture version so that you understand. It's more beeping and more complex. I don't want to scare our viewers, but this, you can see the patient. The surgeon is sat. That could be away 5 meters, 10 meters, and the robot connected by a cable, and every movement is replicated. The robot does not move on its own. Every movement which is done by the surgeon is replicated, and there are several mechanisms in there, like a laser where the head is placed, which once you take your head off, the movement stops, right? So there are a lot of check mechanisms. One of the most amazing technologies that you will see and will be available in every operating room in the near future, and we're glad that we're ahead of the game here. So Nick, going to the next picture, you see this operating surgeon is unique 3-dimensional. We're looking into the console. You can see the joysticks here, and every movement is replicated, and it's 10 times magnification. It's 3D. It's like as if you jumped inside, right? And you've seen 3D. It's fabulous technology. It's just, I can't imagine of another way of doing surgery anymore. And I think in 10 years, it'll be it, right? And I'll tell you some exciting things in the end, what's going to happen, because we are going to change the future and how it's going to change. So the next thing is, we've looked at outcomes, we've looked at costs, we've looked at hospital, we've not looked at what happens to the surgeon. Imagine those two standing, operating, looking into a laparoscopy, you're standing, your neck's unstrained. Think about the surgeon. I would say that because I'm biased, I'm a surgeon, and I would say my patients should all love us. But over a period of time, all this wear and tear will cause neck strain, elbow strain, backache and all these things, because I've experienced this when I was, younger, I'd say, because of my posture and all those things. But if you sat, you're comfortable, your elbows are rest, and you're looking, and you think, all this will help with every step of the operation. And if at the end of the day, you need to have an experienced surgeon. You can have technology, you can have all those things, scans. You need to have an experienced surgeon using technology to get the best outcomes for a patient. So I think that's where this technology is helping the patient, helping the surgeon to get what we want to achieve. Now, I told you about laparoscopy. As you know, open surgery, you use your hands to do all that. Your wrists are, 7 degrees of articulation, and that's what your wrists do. And that's why you can do that. With laparoscopy, you have instruments which will go and grasp, and that's why it's a bit strained. Now, with this technology, with robotics, these instruments are miniaturized. They mimic your wrist, and they get to the point, so your tissue handling is less. So let me put it simply that if you handle tissue less, they recover quickly, right? That's the concept. So if you're going to do surgery, you just need to get to the point closer, really close, hold what's important, do the dissection finely to the millimeter, and not do that gurgling which happens with open surgery. And then the tissues recover quickly, you're not pushing, pulling, and there's less blood loss, there's less pain, and all this will result in better patient outcomes. So this articulating, and this is tremor filtering mode. So there's tremor, you can have tremor because, any fine, like a watchmaker, if you look at a watchmaker, if he is going to work on your watch, it could be a simple or whatever it is, you need to have fine hands. Now, otherwise, if you move these things, a surgeon is also very similar, but, this is even more complex. If you drop something in watchmaking, you could correct it, but here you can't. So technology, this tremor, as it goes through your joysticks and is, the end result in the patient, the technology can filter that so that it's more precise, there's no movement, and it is such amazing technology. And this gives precision, okay? So now this picture gives you scale of these miniature instruments, right? You see, that's a rice grain. That's how small these instruments are, and that's what we're talking about. The rectal cancer may be that big, but just operating around it and getting to where you want to be is just phenomenal. You know, you get so close and you just do that. So the tissue recovery is just so much more quicker. So I'm going to play a video about this robotics technology. I do not have shares with the Da Vinci, company. So this is just a video which shows it. So I was talking to you about the joysticks. These are the instruments. You can see the fine instrument movements. These are the arms through which the instruments are placed in. And this whole technology is all preset. You could just go dock your robot in. Initially, it looks complicated, but once it's all just fabulous technology through which these ports, these instruments go in. They just attach, click. And those are the instruments which go in, the camera, which I was talking to you about, all under the surgeon's control. And traditionally with laparoscopy, you need another patient assistant to hold instruments. Here, the robot can do that for you. The fourth arm is there to do that assistance for you. So technically, you could get less and less people. So you could get, you could, the camera person, as in laparoscopic, so to help you, you have that under control. So you have the two instruments to do the operation, and you have another arm to do the retraction or to show where you want. So you could get one or two people out. So the costing, as it may be, to have manpower to do the operation can be replaced with the robot. Although the initial investment is high, it will, if you have a team which is so focused and does only that, you could get cost-efficient methods of delivering the service using this technology. So in our program, I will show you, it is cheaper. It is almost as cheap as doing laparoscopic surgery, but with better outcomes. So
it's minimally invasive.
So this is the next thing, which is we've talked about multiple ports going in. Now this is single port surgery.
Makes for our patients is unbelievable.
So within one port, all these instruments go. You can see that the camera, the instruments are all coming through one single port. So there is even a smaller cut, and there's less, it's more precise. You can see how this technology, this is the next step where we're going. So quickly look at our outcomes, and this is to do with colon surgery. The golden bar is our outcomes. The silver and the dark gray bars, the dark gray is for robotic from the US data, and the light gray is open surgery. This bar, the darker one, is lap surgery, and darkest is robotic surgery in the US. This is our outcome in Chennai, in our unit. And you can see our complication, wound infection rates, length of stay are all much better because we have a big program and we are subspecialized. Again, looking at the rectal cancer, our leak rates, which is when you join something which leaks, wound infection, our length of stay is slightly longer. That's because patients come from all around the world and they rather stay in hospital and go out, but our readmission rates, because you send patients out, that's what you want to do. You want them to recover quickly and send them. Your readmission rates in the US is 20%, our readmission is 2% because patients get better and then leave. So that's why our length is. So we all be saying is that our outcomes have been very good, comparable, if not better than what's around the world. And our cost is also at 1/3 the cost of what for rectal cancer around the world, and at least half of it for colon cancer. So because of our cost efficiency and methods which we developed so that we can get this technology for our patients. So we have a global collaboration. It works. So these are Prof. Exner from the US, Prof. Manish Chand from the UK, Prof. Lacey from Spain. We have a big collaborative. We work together. We learn from each other. so that this technology and its outcomes and specialization is delivered in Chennai through Apollo, our institute, and we've been doing that for the last 4 years as a collaboration. So we have super specialization, we have robotic surgery and good patient outcomes, and I think that's what's been the key cornerstones, patient outcomes for our patients. Thank you.
Thank you, Doctor. So here I have a few questions for you.
Yeah.
We did speak about colorectal cancer. I have a question. Is it hereditary?
Yes.
Is it possible?
Yes, it is hereditary cancer. If it runs in your family, you need to get screened. So the patient turns up with a diagnosis of colon or rectal cancer. And one of the things which I ask them is that their brothers or sisters or mother, father has had colorectal cancer. Now, the next thing I also ask is because then their risk is high. And then if there is I tell them their children should also be screened. Now, when should they be screened? So if a patient is diagnosed with colon or rectal cancer, let's say 60 years old, normally it takes about 10 years to develop the colon and rectal cancer, right? So it starts from a benign polyp, which is a little lump, which is normal lining, which becomes a polyp and becomes a cancer. So it takes about 10 years. So that's why if you introduce screening, you can pick these up. That's the concept of screening here. So if you get diagnosed at 60 and you had treatment and you're doing well, the ideal time the children should get, the brothers and sisters should get screened immediately. If they have symptoms immediately, if not immediately, the children, if they have symptoms, they should get screened immediately. If they don't, then 10 years before. So if that 60 is when the father or mother had it, the children should have it screened 10 years, like 50. So that's the recommendation.
Okay, so you said in India the incidence is low.
Yeah, 4 per 100,000.
4 per 100,000.
But we have a population of 1.46 billion, in billions. So 70,000. So in England, it's a small country, it has 35,000 cancers, and because of although low incidence, bigger population, we have about 60 to 70,000 cancers.
Yeah, and so how many actually do seek treatment? I mean, you did say the awareness is pretty low, which is the case with almost all cancers. But I guess the colorectal cancer probably comes lower in the line than maybe gastrointestinal or even the other cancers, and in women, of course, breast and cervical cancer. So, how do you make people aware? First of all, how do you prevent them from happening, even if you have a history in the family? Is there a way that you can prevent it?
Better lifestyle. Eat healthy. Cut down on red meat.
Drink. What about vegetarians? Do they also have the same rate of cancers?
See, it's difficult to segregate that. We know that if you eat red meat, your risk is higher. So eating healthy is good. Eating less processed food is good. Smoking is bad. Stop it. Alcohol is bad. Stop or cut down. Just exercise is so very important. Absolutely important. At the end of the day, if you ask me what one thing you should recommend is that smoking out, cut down on drinking, exercise, drink lots of water, and diet. You should, and I think that's very key.
Okay, so this I just want to focus on this drinking water part. They generally say you should have probably 3 liters of water a day.
Yeah.
Would you recommend the same, or is it just like 10 glasses of water is enough, which may be probably 2 liters or?
That's 500 ml. 500 ml.
Yes.
I can drink one of this and do maybe 1.5 liters. That's what I do. I recommend 3 liters because one, you're running around, whatnot. But ideally, each one is different. I would drink two maybe, but 3 is ideal, particularly a place like Chennai, where it's really hot. And also we are in an air-conditioned environment, most in the office or wherever. And so you're not thirsty enough, you are, so that's one issue. Second, if you're exercising, you need to compensate for that. 3 plus whatever you're doing, right? And as I said, the function of the colon is to absorb water, right? If you're not putting enough water, whatever the colon will absorb and the stool becomes hard. And once it's hard, you start to strain. Once you strain, you push, If it's cancer, it's a blockage. Otherwise, it is constipation. Constipation is caused by your diet. You're not eating enough fiber. You're not eating greens. So this will harden the stool, and you're pushing it out, and then you strain, and you develop hemorrhoids or cushions around the anus, which will bleed or become lumps. Or if you push this hard stool through your anus, it will cause a cut or a crack, and it will cause pain. And then, so that's what we'll go. So I think water is very important. We don't give enough there's lots of water around, as we saw in the rains, but to drink is a challenge, but it's important we do it.
Okay. So there's one specific question. Usually the elderly have a problem with constipation. You probably remember that movie Piku, where it was a generalized thing, but then I know that quite a few senior citizens have an issue with the bowel movement. So is that any way related? I mean, I understand it could be in general public, but are senior citizens more prone to having these problems? And
okay, let's put it this way. As you get older, age is just a number. All that is good. But as you get older and older, your muscles, the functions start to slow down a bit. Now with exercise, healthy diet, all that, you keep it up. Now, but if you have diabetes, the background, the nerves for your colon, rectum, anus, all of them slow down. Now, if you had women, I think, don't get enough credit. But let me put it this way, that obviously they, when you have a delivery, for example, normal delivery in particular, you have a 40% chance of damaging the muscles around the pelvis, where, that's where, so the whole evacuation process is a complex one. It's fascinating. I find it extremely interesting, challenging. I can't understand a bit of it. But as in my practice, I know a bit more, but it is a very complex interplay of muscles, nerves, age, your comorbid conditions like diabetes, all of these things. So 40% of women who have normal delivery have damaged these muscles. Now, as you're younger, your muscles are stronger, you compensate for it. As you get older, these muscles, every muscle bit will become thinner in your body, right? So your evacuation, your control, all of that becomes weaker. So the point I'm trying to make is women are special. So let's give credit to them on this Hindu webinar. That's one. Two, in general, as we get older, these muscles get weaker, the pre-existing kind of diabetes and things like that. Your bowel, the way it's pushed forward is weaker. So you will have evacuation issues. Now, taking some laxative is not, patients come to me and go like, doc, do I need to take this for life? And I go like, yes, you should. It's like you have high blood pressure. You're taking a pill. So you need something. Constipation is not going to cause cancer. The simple ones are because you're not drinking water. You can change your lifestyle, but you can take a laxative. They're pretty safe. You can get dependent on them. The person who get dependent on them, I'm not saying everybody should take it. I think you should build your lifestyle, improve it, exercise, eat healthy. And then if you need see a doctor, and then if you still need a drop of a laxative, that's good enough.
Okay. So here is a question from a woman doctor. She says she is 71 years old, and she has slow.
What's her name?
Her name is, it's a man, Kandasamy Ramanathan. Sorry, okay. I got it wrong.
Okay.
It's a man.
It's nice to put a name. Hello, Mr. Ramanathan. Okay, that's okay. Go ahead.
So what are the tests you would advise for a 71-year-old female Sjogren's patient?
Sorry, slow?
Well, I think that's what it means. Slogren apostrophe Sjogren's patient. I don't know whether it's the name of a person or what. And she has irregular timings in daily bowel movement. So I think this is
SJO.
Yes, that's right. SJO.
Yeah, it's a condition which is okay. So it could affect the intestine. So I think what they need to do is just to see a specialist and get an assessment done, because you could do millions of tests. For me, I think just taking medicines or tests based on because you may not need it. I think they should see their own doctor and see, okay, they have bowel issues. Could they go see a specialist who deals with this? And it could be something very simple, which is not related to Jordan syndrome, or maybe related. Now we need, because the test is slightly different. So I would suggest that they go see their own doctor and then go see a specialist, and then we can work it out.
Okay, so there is this person called Arun Samuel. He says not every surgery is 100% successful. So what is the success rate of this robotic surgery?
Okay. Hello, Mr. Samuel. Good question. Now, it shouldn't matter regarding the success rate, whether it's open, lap, or robotic. That's one, right? Now, because the technique, because I was taught to do open surgery when I started training about this, it was open surgery, and by the time I finished my training, it was laparoscopic surgery, and then we picked up on robotic. But the technique is the same. Now, why this robotic surgery makes a difference is that, one, because of less tissue handling, the recovery, pain, it's all quicker. Pain is less. There's less tissue blood loss because you're handling it. Now, particularly for rectal cancer, which is very close to the anus, where we are trying to remove, because if your anus is here and your tumor is there, you have to cut some healthy bits so that it's joined. We can't cut through the tumor and join things together. Now, the reason I didn't put that, technical stuff is it just complicates it. Now, what we need to do is, if the tumor is there, you can cut healthy bit and join it back together. The anus will still work. Now, if it's very low, the pelvis is where this rectum and anus are and where the tumor is. Now, in females, because of evolution and childbirth, the pelvis is wider. Okay, so I thank God every time I'm saying, okay, it's a female pelvis out there, there's a little more space, it becomes easier. A male pelvis is more challenging because they're more muscular and they are narrow, more pelvis. And tumors are all more bulkier too. So imagine that there's only that much space and the tumor is like that. You don't have much space. That's where this technology, you're looking deep into the pelvis and using your camera to go in and using these fine instruments. So in our program, what we're seeing is that we're able to clearly remove lower and lower tumors, remove them and join them. After this initial chemo and radiation to shrink the tumors, in our program. Now, lots of people, surgeons might even argue, I will do it open. You have to feel the tumor, this technology or this planning but again, if you go back, we have CT scans, MRI scans, PET scans. It will tell you if the tumor is so large, you can do it open or not. If it's large, you do it open. Even I would do it open. But if it's a tumor which is resectable, which is safe, but it's very low technically, because if you cut and look, you can't really see what's happening deep in the pelvis. A lot of time you're doing it blindly. You're struggling. Even laparoscopy, because it's all straight technology, you can't really get to the angles. With this technology, because it's flexible, you can get to really low levels in the pelvis and achieve resection margins safely, right? And so again, each surgeon is different. Right? But this technology is allowing us to do much safer surgery. Our complication rates are lesser, we can only, which are to be published because we're reaching 500 of these procedures, which is the highest volume in this country. And we can't do 10 of these and say, look, we have a big program. We need to get to 500 and we'll be there, soon. And then we'll get this published and then that data is there. So I think as Mr. Samuel says, what is the benefit? So these scans will tell you if you can do it open or not, so that there is no confusion there, right? Only thing we can achieve better outcomes, functional outcomes. Now, there are also nerves in the pelvis which these tumors are right next to. Now, the standard has been you cut these tumors out, you join it back together, and then you end. But now we are thinking about functional outcomes because the cancer clearance should be the same because the technique of going, but you're able to do more sphincter preserving, which is the control thing. Otherwise, they'll end up with a permanent bag. What we're able to do is go and remove it and join it back. So we're doing more sphincter preserving procedures with this technology in our practice. People might argue, we're not going into that. In our practice, in our high volume center, we're able to do that. Also, because of three-dimensional views, you're able to see these nerves. Now, I routinely operate on 18, 19-year-olds who get rectal cancer, right? Now, you could get the rectal cancer out, but damage these nerves, which are important for sexual function, urinary function, and control. So if you are not in a high volume practice or a high volume center who's doing this regularly, right? And you've given radiation, chemo, it's all a bit swollen, and if you damage any of these nerves, these will get affected. Now, cutting it out and getting a good margin, okay, but you don't have to cut things which are not necessary and important. So the functional outcomes become important, and with a high volume practice or a center like our center, we are looking at those things so that these functional outcomes. So if I operate on 1820 and if they're going to meet someone and have children or have their sexual function control, all this is important. It may be not important to people who don't know about it, but patients who are. What we're trying to do, get them as normal as possible. Not the same, but as normal as possible. And so that's why this technology is so important. And there is evidence to show that we can preserve these nerves better.
Thank you, doctor. That was really interesting and very informative. So here is one person, Chandru Natraj. He's asking, how affordable is robotic surgery when compared to open laparoscopy, given the cost, given their benefits?
Yeah. Good question. Good question, Mr. Naval, and I like that because I think any technology is, unless every man on the street can use it, it's not really truly reached its potential. Now, we are one of the biggest hospital, oldest corporate hospital in the country. We have the technology. If we can't deal or deliver this technology or the service or the outcomes for the common man, then we also have it. So what we've done is, that's where the efficiency of having a well-trained team, because it's not about one man. I go do a bit of the operation, which is to dissect the tumor out, and there we have an entire gamut of surgeons, nurses who work together to do the operation. So it, everything, time and cost is reduced, efficiency is increased, so that the cost of technology is compensated by being more efficient, right? So in general, open is cheaper because you're cutting and you're not using any of the advanced technologies. So if, let's say, if it is, say, 5 rupees, if it's, to do a cancer operation, I'm just putting a number. But you have bigger cut, slower recovery, more pain, all those things. With laparoscopy, the cost is maybe 7 rupees, I would say, or 8 rupees. Let's say 7. I'm just saying, proportional.
Yeah.
But it's smaller cuts. It's more challenging. Skill sets are difficult because it takes long hours to do, and you need to have staff. All that has costs. So robotics would say we were 10, but what we've done is to bring it down to 7 by doing lots of removing unnecessary things. So in our program, our lap and robotic costs the same. Now, how will you achieve it? If you're doing one of these or two of those in a month, you will not achieve the cost efficiency. You need to be doing 10, 20 a month. For that, you need to have a subspecialist practice doing only this, not a bit of stomach, bit of pancreas, bit of gallbladder, bit of this, because you will have 3 of that, 3 of this. We are having 100 of colorectal per year, for example, right? And so your experience, outcome, everything. And then you can find all ways to bring this technology to cost efficiency and then deliver it to everyone in the street. So that's the answer. So in if you're subspecialist, if you're cost efficient, again, all that data is now ready with us, which we're going to publish once we reach that particular number. And we can achieve costs similar to that. Now, not everybody can do it, only if you have the numbers, experience, and volumes.
Yeah, thank you. Volume is the most important part there, I guess. And so you become efficient and you'll have more patients coming into you. Yes. So here is one, K. Narasimha Keshavamurthy. How do you compare the Indian-made surgical robo versus Da Vinci robo, apart from being cheaper? Do we have an Indian-made surgical robo?
Not in the mainstream. because not in the mainstream it's available. There are a few things being developed. There is the Da Vinci, which has been there for almost a decade in the fourth version, right? And then there's Medtronic Hugo, which has just been introduced. We have one of those in our main hospital, and we've already started using to urology, and we're going to be using for gastrointestinal. So the point is to have, and then there's CMR surgical. There's a few more available, but these are three main things which are available in, there's something called monthly, which is just getting, but I think, again, technology is being developed. Given another 10 years, there'll be multiple things, very specific things. There'll be specific things of, say, a breast or a thyroid or whatever, and every theater will have some form of robotics. But what I'll tell you is will be fascinating and interesting, and I think which will change the world, as I said. If you think about it, this robotic technology was developed by the US, for their, the Army, Air Force, Navy, primarily for remote surgery. So if there is a war going on the battlefield, you can't have specialist surgeons to go and operate. So they wanted to develop a technology which will operate, which will be robotic. As you can see, Amazon has got these robots which go and stack up things, right? We have drones to deliver. Now, just think about this. So this technology was developed for that. So you have the robot, you have the console, you have a wire connecting it. Every movement is replicated. Now, what we're doing, take the wire out.
Wireless.
So I could be operating from this room in your office there. It could be Japan, it could be the US, or it could be in a gray tower in New York, right? The point I'm trying to make is now there are two things which need to be corrected here or addressed. One is the latency. When I make a movement, what happens in the patient? One. Now it's about this technology already exists on Wi-Fi. We are on 5G. Imagine how we jump from 2G. We know that story. 5G. It will be we'll leapfrog into 8 or 9G within the next few years. That's going to happen. Whether you like it or not, it's going to happen. And then the latency between movement is 0.8 seconds. If you can bring it down to 0.2 seconds, then this will work, right? Then the question comes, the patient public might ask, look, doc, but you're not there. Well, I'm here. I'm talking to you. I can move. I can do all these things. But that's where we develop teams who are as good as, or, I wouldn't say the team should be equally good. And then you send them out to the Himalayas, right? Himalayas, it could be Kashmir or, Himachal, wherever. Or it could be Kanyakumari, or it could be Hyderabad. And you could centralize this expertise because, as I said, you're subspecialized, you're an expert. Why do you need to have 10, 100 people doing the same thing elsewhere? You could centralize it, but you can use this technology to go, and your team goes out, ensures that if there is an issue, they can address it, finish and come. Because it's like the US Navy SEALs. They're all good, they all got their back, and they will be employed to go and extract, like the Osama bin Laden story, right? Everyone's responsible, right? So the reason I'm saying that is that your team is the core in this. Then you have technology to address that, and then the possibilities are infinite.
Thank you, Doctor. So here again, I think Mr. Chandru Natraj has a question on what are the kind of lifestyle changes? You've already touched upon it. So I think life changes modifications you would advise to prevent colorectal cancer.
So just to quickly
recap,
have a healthy lifestyle. One, you drink lots of water, more greens, less meat, go vegetarian if you want, it's good. Definitely I eat more veg. I've cut down on meat. Yes, I enjoy it, but lesser, and then exercise. Exercise is so very important. You need to start exercising. It could be walking, cycling, whatever you want to do. I think that's very important to, watch your tummy, lose weight. If you lose weight, all your comorbidities like diabetes, hypertension, all of them will improve and you'll be off medication. Now, why would you want to not do that? It doesn't make sense to me. And then if you're a high risk, if there's a family history of colorectal cancer, or if you have some condition called ulcerative colitis, you could be more at higher risk of developing. So then you have to get screened. So yeah, that's the advice.
Thank you. So here there are two questions from anonymous attendee. I don't know if they're the same person or they're two different people, but they have this question.
I love anonymous people asking questions.
Yes.
It's always-
So is there hands-on on robotic surgery for DNB general surgery residents in Apollo? That's a very specific question. And then in the near future, do you think every surgery is going to be done by robotics? I mean, will the robots take up all surgery is what he's asking.
So one, I think just to answer the training bit, the training bit is we are looking at an FNB for colorectal. We have DNB for gastro. They can apply and come and do the training there. But they're most welcome to come and chat with me. I'd love to talk to, because I know when I was younger and somebody showed me the path, so I think I'm happy to have a chat and show that to, talk to them about it. There will be some form of robotic automation, parts of the operation, movements, yes. We have lots of technology now. We're going to get, the CT scans, everything, if you press a button, it'll go what's that Tom Cruise movie, which, it's not coming to me, but where this whole thing, if you put a card, the scan, so you could press a button, all this, it will get augmented reality and virtual reality. You could, when you're seeing inside and looking at the anatomy inside, it can show the blood vessels and important structures and say, hey, because the computer already extracts what I do and what the important structures are from, say, 500 of mine. It will say, Venki, every time you put that over there, that's where it is. You're very careful there. So that structure is going to be there. So somebody who's training, like new coming into the field, they can get warning signs to say. So that's where this technology is going, right? And you can do this. That's augmented reality. Virtual reality is you can create this anatomy outside and you can do the procedure. Now, will there be a fully automated operation? Wow, I'll lose my job. I hope not. But again, we didn't know this technology would be there 10 years ago. Yeah. Then maybe I'd be coming and doing webinars with you and maybe interviewing the robot. I don't know. I wish, if it is going to anything which is going to make it safer for the patient, I think we should. But I think a fully automated operation is not going to happen. An augmented operation will be there, which will make it safer for at the end of the day. We just need to make it safer and better outcomes for the patient. Yes, there is a, cost and all that. You could still make it cost efficient. At the end of, we can make it work for India. Yeah, and I'm sure we can do that. And but I think there will be some automation. But it will be still supervised, even if there is completely supervised by a doctor. I think if I go for surgery and if my surgeon tells me, Doc or Venki, that your operation, you need a toenail removed, for example, will be removed by a robot. I said, okay, Venki, you need your heart replaced. No. Do you know what I mean?
Yeah.
Yeah.
So here, Dr. Ethirajan Bhaskaran, as a researcher, I want to do, I want so much to, what's he saying? So I think he's too much of the cost of the robo. How much fee is charged by Apollo for doing this surgery? Dr. E. Bhaskaran, Joint Director, Engineering Department of Industries and Commerce, Government of Tamil Nadu, Guindy.
Wow.
I think he says, I want to know how much is the cost of robo and how much is the fee charged by the Apollo Hospital for doing the surgery.
Yeah. So doctor, wow, I would love to come and visit your department, see the kind of work you're doing. And you're welcome to come and have a look what we're doing because it's fascinating stuff. So there is a robot cap cost. Okay, let's put it, say the robot costs about 16 crores to get today. That's the standard. There's a version which is about 12 crores, 10 crores. There are other robots which are around that range. The instrumentation can be cheaper, expensive, but we've had one player for a very long time, but it was amazing technology. Now that there are multiple players, the cost of the original player is also coming down. So it may add up between, say, 70 to 1 lakh rupees minimum extra or 1.5 lakhs extra to use the technology. But again, that's where I'm saying if you're a high volume center, you will get all those efficiency practices in, you could match those costs. And that's what we're doing. And that's why I'm super excited about this technology and our program, because where you can get the outcomes with using advanced technology, you need to find ways for our country. And if we can do that, and I think we'll do it, but it will on the whole cost a lakh or lakh and a half extra. But in a high volume center, we are able to compensate for that cost and keep it same to that cost.
Thank you, Doctor. So here is Shravan Raj. Is this technology also beneficial for treatment of hemorrhoids? If someone went for an open surgery for piles and in just 3-4 years, bleeding started again, should they go for robotic surgery?
Okay, so I would love to use a robot for everything because it's good technology. It's very fashionable. I think it helps the patient too. But that's primarily for abdominal surgery. Transanally for tumors, we use this tumor, but hemorrhoids, no. But there are robots being developed very specifically for these things that will come in the future. It's not worth the cost at this point in time. If you had previous surgery and if you're bleeding again, probably there is a recurrence or it could be another problem. So you should have a screening colonoscopy or a sigmoidoscopy or see a specialist to first assess that and then have a screening done and to be reassessed.
Thank you, sir. Here is somebody called Mr. Sivakumar who has a question. Ulcerative colitis, will it lead to cancer in the future?
Yeah, so ulcerative colitis is part of an inflammatory bowel disease. There are two of them, ulcerative colitis and Crohn's disease. Crohn's disease affects from mouth to the anus. Ulcerative colitis affects only the colon rectum, primarily starts from the rectum and the colon. And yes, it can predispose to colorectal cancer. If you have it for 10 years, you're 1%. If you have 20 years, you have 10% risk. So yes, the answer is, so you should get screened. If you have ulcerative colitis for many years, you should get a screening colonoscopy done.
Thank you. Somebody called Sudarshan Venkataya. So one of my relatives has left ovarian tumor and it is involving sigmoid, okay, and colon, sigmoid colon.
Yeah.
And it was removed.
Mm-hmm.
What is the chance of recollection?
Recurrence. So these are advanced cancers now. Either we have to see if it is a colon cancer or a ovarian cancer. Which one was struck on which one, right? Now, these things can be complex. The ovary and the colon has to be removed. If there's any peritoneal disease, these are advanced cancers. Your first shot at treatment is most important. Now,
and doctor, she is on colostomy bag.
Oh, okay. Okay. So, no, I understand why they would have done it, but it's just a bit complex to explain. She needs to be screened regularly to see why she was not connected back if it is advanced disease. So I'm happy for them to email me the details and I'm advise them accordingly because a little bit more thought needs to go into what was done and what we can recommend for the future.
So here is an anonymous attendee, but she has given her name. She says her name is Nivi. Our family has the history of familial polyposis.
FAP, familial, yeah, adenomatous polyposis.
My mother, age 60, has been advised to have it removed, I guess, have the colon removed and keep a permanent, I think she says ostomy bag outside for life with after the age of 60, and it's very difficult. So
FAP is a condition where you get hundreds, thousands of polyps in your colon. They will all turn into cancer. It is a familial thing. So that's one condition where the whole family needs to get screened, particularly the children, brothers, sisters, and all of them. Now, the only way to cut the risk is to remove the entire colon rectum. Now, if you're younger, we could do a pouch, make a small intestinal pouch to replace it and attach it back. Right? We do that routinely over here. Now, if you are 60, if there is no tumors in the rectum, if there are any age, if there are tumors in the rectum, then I wouldn't do the pouch. You end up with an ileostomy. We can reconstruct it, but she'll be running to the toilet 6 to 7 times minimum. There will be urgency and all this. Although it is difficult, colostomy is not a bad thing. You may have better control once you get used to it. You need a nice stomach-therapist to sit and talk to you, advise you, because it's a psychological thing. It's people with colostomies, ileostomies are on the golf course swimming, jumping into the sea. So the question is whether they need to be counseled, educated. So at 60, depending on how good their muscles are, the muscles are not good, we can't join it back. If there is a rectal cancer very close, then that's no. So because you don't want to be sitting in the toilet or running the toilet all the time, you don't have a quality of life. You might as well have a bag. Once you get used to it, you'll be okay. So yeah, some people will hate it. Majority of the people will be okay and move on with their lives.
Right.
And please check question from one Mr. Pandyarajan.
Hello, Mr. Pandyarajan.
I haven't got any Pandyarajan here.
He asks, sir, I underwent colorectal surgery in 2015.
Yes, in Tiruchi, using bag permanently. Is it possible to be back to normal?
So if they have removed the rectum and the anus, no, you can't at this point in time. Again, because there will be an end, I can't connect it back, or you can't. It could be in a very low tumor, so that's why you remove everything. But who knows the future? I'm very hopeful because today we make decisions based on what's is available today, and we want guarantees, or can we change it in the future? Tomorrow is a completely different day. Technology will change. We may grow stem cells, and we will grow an anus. We may transplant a pig's anus. That's all happening.
Yeah,
or an animal
like we
anus.
have done things.
Yeah. So we could have a template. We use 3D. Where that 3D printing. We could use stem cells to create it. I think the possibilities for the future are infinite. We just need to be hopeful and stay positive. And if you don't hope, but you should stay hopeful. And as of now, maybe not, but you never know, because there's technology research going at breakneck speed. There will be trouble, and we will get up after that, but it may change. So just keep looking out for answers.
Thank you, doctor. Here is one person, Maithili Sivakumar. She says, my spouse has been diagnosed for aggressive agiomyoma. I'm sorry, I don't know what that is. AGIO myoma, agiomyoma in pelvic region.
Okay.
So MRI reveals a lesion the size of 164 into 69 into 66 millimeter. Will this be the best procedure? Okay, so I think she means robotic surgery will be the best procedure to remove.
We just need more clarification. If she can get in touch with us by email, the details will be there. Just get in touch. Happy to reply, or send a WhatsApp. Sometimes it takes time for the emails to come back, but the WhatsApp will work. So just send the details, and I'll advise accordingly.
Right, sir. So there's one question here again from an anonymous attendee. Is robotic facilities, are there the facilities for robotics and trained professionals in Apollo hospitals, are they the same in Bangalore and as compared to those in Chennai?
The technology is available there. There are surgeons who are doing it. Obviously expertise varies, and depending on local, you just need to find out what's the best thing available. But it's in our network. There's Bangalore, there's Hyderabad, Delhi, Calcutta, Vizag, and Mumbai. So within our network, that's we have technology and surgeons doing those things.
Thank you, doctor. Here is one person, Shanmuganandam Sachidanandam. So he says he was diagnosed for rectum cancer and is undergoing treatment. Radiation and 4 cycles of chemotherapy have been completed. 6th cycle of chemotherapy would be completed by mid-December 2021. So he says, can he approach you for robotic surgery? He's asking.
Happy to help. Happy to help. That's why we exist. Email, come and see us. Happy to have a coffee and discuss the reports, and we'll see where we go.
Okay. So is this technology, this is from Shravan Raj. Is this technology also beneficial for treatment of, I think I asked this question, also beneficial for treatment of hemorrhoids?
No. Not yet.
Oh,
Not yet. We're not using the robot as yet for hemorrhoids. I wish I could use it, but yeah.
We can take 2 more questions, ma'am. We are running out of time.
right. Okay. So there is just one more question here. I think we have time only for 2 more questions, they tell me. So there's one here. So to avoid the rate of infection, can suprapubic robotic surgery, can it be done safely? So I think suprapubic.
Yeah, I mean, with any minimally invasive thing, there's less handling, so wound infections and things are much lesser. So yeah, do that.
Okay, so I think that is about all, and I think we will have to close here because we don't have time. Thank you very much, but this was a very interesting session and you made it extremely informative. And I'm sure a lot of people had lots more questions and some of them were really inane, some that are very commonly asked. And yet you took all the questions very well. Thank you very much, Doctor.
Sure. Happy. And if anybody got questions, they can email us.
Yes,
or
we will email
WhatsApp us and we'll sort that out. Thank you, the Hindu and Sujata, for your time and patience. Thank you.
Thank you, Doctor.
Thank you.